My name is Russ Derry, and I'm the Director of Education at Epilepsy Foundation of Michigan. And the topic today is epilepsy diagnosis, and we're very happy to have with us Dr. Nikesh Ardeshna, who's an epileptologist with Spectrum Health. So, Dr. Ardeshna, can you introduce yourself and just give an overview of your experience working at the Spectrum Health Comprehensive Epilepsy Program and your clinical and research interests and your experience with this particular topic as well?
Sure. Thank you for having me, and good afternoon to everybody who's there, although I can't see you in person. So my name is Nikesh Ardeshna, and I'm currently the Director of the Epilepsy Monitoring Unit here at Spectrum Health in Grand Rapids as part of their comprehensive epilepsy program. Prior to this, I used to be as part of an epilepsy monitoring unit in Indianapolis, Indiana, and I was actually trained in Detroit, Michigan, where a lot of you are close by. My interest, actually, my focus as a whole has always been reading of short and long-term EEGs, and clinically, my interest focuses on seniors with epilepsy. And in addition, most my little spare time is spent working with the Epilepsy Foundation in Washington, D.C., with respect to advocacy for children as well as adults who have epilepsy.
Great. So let's start, again, the topic is epilepsy diagnosis. So let's start by talking about how an initial diagnosis of epilepsy is made. Are there formal objective criteria that must be met for a person to be diagnosed with as having epilepsy, for example, having 2 or more unprovoked seizures, or is diagnosis more subjective and based on clinical opinion?
Well, the first thing is, even with, and I believe there are 2 people on this call that I heard that are currently in an epilepsy monitoring unit or work in an epilepsy monitoring unit. Is that correct?
Yeah, we have 3 people who work at Beaumont, actually.
Okay.
Yep.
At Beaumont. Okay. So the answer is that the diagnosis, epilepsy still, at least until proven otherwise, will always be a clinical diagnosis. So your first assessment is always made via history, physical examination, with the bulk going towards the history, such as episodes that the patient has had. The formal sort of definition for epilepsy is 2 or more unprovoked seizures. Now, the thing is that at least I would say a good third of people are calling that into question, because even though that is the formal definition, is that the definition that we all abide by all the time? The answer is no. A lot of the analogy you have to use is that with respect to diagnosis, and eventually, as I'm sure you're going to talk about, treatment, there is a lot more flex with respect to epilepsy than there is with such things as a heart attack or a stroke. But the two things that you always parallel first is, as I said, a good history and physical in a consultation, followed by if somebody has had 2 or more definitive unprovoked seizures, they would meet the definition of epilepsy, and at that point it is recommended that they start on anti-epileptic medication. Where the variability in that comes in, and I'm sure a lot of you know this, is what if somebody has had 1 definitive and 1 episode that's kind of questionable? And that's where all this additional investigation comes into play. I will tell you one thing, and that's just by virtue of what we are seeing now. We were trained, the majority of us, with this definition, as I said, of 2 or more unprovoked seizures means epilepsy, and they get started on medication. But the biggest flexibility to that is, for example, when somebody has had 1 seizure and they have some other risk factors. For example, they just had a significant head injury, or they had a stroke, or they're discovered to have a brain tumor. At that point, people usually make the diagnosis much more quickly with bending the definition.
Okay. And is that true also another risk factor could another risk factor be an abnormal EEG?
Yes.
Or
So
like interval EEG, I guess.
Absolutely, yeah. So let's say somebody's had one seizure and a markedly abnormal EEG, and I thank you for bringing that up. That is correct. That is absolutely correct. The one thing to go back to the very first part of your question is when you make the diagnosis, remember you never hinge your findings on one test alone. It's the combination that matters. For example, if I had hypothetically had two unprovoked seizures, let's say one in March and one in July, my EEG could still be normal. So a normal EEG does not rule out the diagnosis.
Right. Okay. So people get the diagnosis in many different settings, and many different physicians might make that diagnosis. And I would imagine that the variability of that setting can impact the reliability of the diagnosis to some extent. So can you talk about that variability between different settings and providers? For instance, getting a diagnosis with an on-call neurologist and an ER, or a diagnosis from a general practitioner, or versus an epileptologist. How does that impact the reliability of the diagnosis, and how often do you see patients who've been misdiagnosed?
Okay. So with respect to that, to go to the first part of the question, if I had my perfect way, and this is what we recommend as we work with the Epilepsy Foundation and all of you as well, and to your existing patients and to friends and family, is that anybody who has epilepsy or suspected epilepsy, or for that matter has a seizure, should ideally be seen by an epileptologist for an evaluation or a consultation. So we are going with the issue that the best reliability of diagnosis is usually when seen with an epileptologist, but I think we all know that that's easier said than done, especially in different parts of the country, even in our country as a whole. So that would be number one. There is variability. I'm not going to deny that. Is there, obviously, if I had to pick in ranking who would be the best to see, an epileptologist, the second would be a neurologist. And then there's always a lot of input is obviously seen from primary care, but we encourage the primary care doctors, be it family medicine doctors, internal med, something like that, to refer to at least a neurologist so that somebody can be managed appropriately. Even if there's no changes in their medication, at least the confirmation is, hey, you're on the right track. To talk about settings where you mentioned, okay, where do you pick up this diagnosis? Yes, some people will pick it up in the family doctor's office when they mention, the doctor will pick it up just by the patient mentioning it. Yes, there is a lot of people that come in with a first-time event or a recurrent event to the emergency room. Now, that's where the difficulty comes in. The emergency room often gets the diagnosis correct. Okay, they can also be incorrect about it. But the difficulty there is if they get the diagnosis correct, often the medication and stuff that is chosen is not the most ideal, but temporarily it will benefit the patient. Right. On the flip side, where you said, okay, could there be a little bit of a lower reliability with any other practitioner who doesn't see seizures as much? The answer is yes. I would say that a fair number is anywhere between 25% and 33% of patients that we see come in with the wrong diagnosis, but what is epileptic is thought to be non-epileptic or vice versa. Or non-specific spells, like sometimes what is called syncope may actually be a seizure when we take the history.
So what are you mentioned being diagnosed with non-epileptic seizures, or what are some of the other common conditions that can be confused with epilepsy? Things you have to rule out, or things that you commonly see people misdiagnosed as having?
So the big ones there, the first thing is, and a lot of this also depends on whether the patient is in hospital as an inpatient or outside. But as a whole, if we look at it, whenever you're thinking you're working somebody up with potential epilepsy or saying this is their probably likely to, you think about stroke, you think about TIA, memory loss comes into play, fainting spells come into play. Syncope is often that fainting spell diagnosis that you will hear. We've even had people diagnosed with the, quote, abnormal behaviors, which people then realize, hey, wait a second, these are manifestations of seizures. To tie back to what you said, perhaps the way that a lot of people, and I wouldn't say this is purposefully done, but why the diagnosis can be delayed or missed is because, and as you all know, seizures present in so many different ways, and that's where the dilemma comes in.
Right. Are there particular factors that complicate diagnosis, or groups or populations where it's harder to come up with a diagnosis? I would imagine older adults would be one such group.
Absolutely, you are correct. Older adults, it's a little more difficult because sometimes people think, oh, this, number one is older adults, as you said, they have other conditions that sometimes complicate the history. They have Alzheimer's, they've had a stroke. Of course, the older you are, it's harder to dig on the prior history when they were younger as you try to dig in and say, hey, was there anything like that going on? Patients who have other mood disorders or memory disorders or traumatic brain injury, it's harder to get an accurate history. The other difference is when somebody lives alone and somebody hasn't witnessed some of these spells, that makes the diagnosis even more complicated.
Right. So before we talk about EEG and neuroimaging technology, we'll go into more detail on those later, but can you talk about some of the other key tools and steps that are involved in the diagnosis of epilepsy? You've obviously mentioned patient history, but what are some of the other steps that you find most valuable?
So the standard of care right now, and this is actually where the standard comes in. What is recommended, and that's what we do here, is obviously a comprehensive history, a full neurological exam, and then an EEG at least, a routine EEG at minimum, and some recent intracranial imaging. So basically a picture of the brain, and it is highly preferred that now is an MRI rather than a CT.
Okay. And then during this process of the history and the testing, how can patients and family members help doctors during this diagnostic process? What are some of the key things that they can do to improve the likelihood of an accurate diagnosis?
Best thing would be obviously keep a log of any events. Family members, sometimes we encourage family members to come in and talk if they've witnessed any episodes. What happened? Can you describe them to me? We've even had some people bring in videos of their episodes, so that sometimes what we are thinking, it's all by recollection. A picture is worth 1,000 words. The other thing that the family can help out in, which it seems, again, all of these seem very obvious, but you can imagine that in the heat of the moment, a lot of issues are forgotten. They're recalled later, just like after the patient leaves the office. Were there any particular circumstances that led up to this? Was the patient ill? What time of day was it?
Right. So in some cases, the decision regarding whether to treat a person who's had one or more seizures is not as clear-cut as you might think. So can you talk about some of these circumstances and how that decision is made? For example, if you don't have a clear diagnosis, or maybe the person's only had simple partial seizures, or maybe epilepsy might be suspected, but there's only been one seizure experienced. So in those types of situations and other situations, how do you determine whether to start treatment?
So the answer on that one is the easiest answer is when there is uncertainty, it basically means we need further investigation. Whether it is, a 6-hour video EEG, a prolonged EEG in the epilepsy monitoring unit, something to give us more data. Now, in some cases, of course, there are times where even if you get the additional data, it's still a little ambiguous because there's some subjectivity to it. As a whole, if someone has had two defined, unprovoked seizures, at that point, that's the simplest. You basically say that this person needs treatment with anti-epileptic medication. If it's one with a risk factor like we talked about, most people are leaning towards treatment. On the other hand, if it's just been one with no other risk factors and some clean data, there are times where you just have to take a wait-and-see approach, and you see if the condition declares itself. I had a patient about 2 months ago, where we were exactly in that quandary on the first visit, and I specifically said, we're just going to, take a wait-and-see approach here and see what happens, because his first seizure, it was clearly a seizure, but it may have been medication-related, because right around that time frame, there was a significant number of changes that had occurred. However, 4 weeks later, I got a call that totally unprovoked, he's had another one. At this point, then, I'm ready to make a decision.
Right. And what about the case of simple partial seizures? If someone has only had simple partial seizures, they don't impact your awareness, so it's something that you can theoretically manage with fairly well with little impact. But you're at the same time you're at risk for that generalizing, and so how do you deal with those? And I guess, of course, it depends on the individual, but in general, how do you deal with that situation?
So it is actually, and you are 100% correct, that simple partial seizures, though they don't look as ominous, they are treated in the same way, and that's sometimes something we have to convince patients of. You're aware of them, you can function during them. But like you said very accurately, the failure to treat them can potentially increase the risk of a grand mal seizure. So the answer is, even if it's any type of seizure, be it simple partial, complex partial, is still treated the same way. The other thing that is very important to note there is a lot of times patients have auras. And the auras originally were not thought to be seizures. Now they are considered as an equivalent to a seizure. So their reporting of auras also is of very great importance in terms of treatment planning and adjustment of medications. So the actual clinical seizure counts, but as well as aura-type symptoms.
That brings up another question I had, which is when people present with a grand mal seizure or a complex partial seizure, and what's a fairly obvious seizure, and then you go back and ask them about their history, and how often do people say, oh yeah, I guess when I was a kid I did used to have these funny feelings, but I never told anyone about them, or I had these staring spells, but I didn't think anything of them. How often does that occur?
I wish I had a percentage. It's not that often, I'm going to tell you. It's not that often, but that is the question that I ask them. That's actually that's virtually everybody I see, in fact, today in clinic for my new patients, that's something I'm going to ask them. Because, as you said, most accurately, it's often overlooked at that time, maybe not purposefully, but it's thought to be, it's a child being a child. But you do see that, yes.
Okay. So, under what circumstances should a person who's been diagnosed with epilepsy or a person who's been told that they don't have epilepsy see an epileptologist for a second opinion on their diagnosis? Because a lot of times people get the initial diagnosis, but then they may not feel comfortable with that. How do they know when to seek out that second opinion with an epileptologist?
Well, I guess the bottom line is personal choice. That was number one. If you don't feel comfortable with the diagnosis, or let's say you wanted more information to clarify. Let's say if it was the primary doctor that made the diagnosis and you as the patient thought, okay, I want to make sure because I want to see a specialist of this. That's perfectly logical. However, when you get into the situation where, if you get a second opinion, let's say you're being managed for years, and we do have a lot of patients, particularly in this area, who've been managed for years by their family doctor or their internist, and their seizures are not controlled. That is, they continue to have breakthrough seizures while on medication. That's a very good reason to see an epileptologist. Another possible reason for a second opinion is, let's say you're looking at treatments other than medications because your seizures are not controlled. That's another possibility.
Okay.
Or a third possibility would be, let's say the patient is having spells which were deemed not to be seizures from a history standpoint and an evaluation standpoint, but the patient continues to have spells or the types of spells change.
Okay. And one of the common, conditions that you have to rule out or that is confused or misdiagnosed is psychogenic non-epileptic seizures. How common is it at a comprehensive epilepsy center? I've heard all different percentages, but what percentage of people that are referred to your comprehensive epilepsy center actually end up having a diagnosis of psychogenic non-epileptic seizures?
I would say, now this number varies, and you are correct. You may even know these numbers better than I do. It's a good 40%, 33 to 40%. Some people actually statistically have shown across the country that in an epilepsy monitoring unit, the admissions approximately anywhere between 30 and 50%, have the non-epileptic seizures. But one thing I will caution you, and this is case in point, virtually every couple of days we run into this, if not every day, is remember about a third of patients with non-epileptic seizures themselves, even if they're confirmed, also have epileptic seizures. They have the mixed disorder.
Right, that's an important point. Okay, and so because misdiagnosis does happen, or sometimes you can get an incomplete diagnosis or inaccurate, what are some of the potential consequences when treatments decisions are made on this incomplete or inaccurate diagnosis? Just to let people know why it's important to get a solid diagnosis.
So consequences would be, let's say you're not being treated optimally and you continue to have breakthrough seizures. Well, maybe breakthrough seizures can lead to memory problems, potential for injury, and potentially even a fatal injury. On the flip side, if you've been seizure-free, or let's say you don't have seizures and you're still on medication for what are presumed to be seizures, do you really need to be on a medication that you don't really need for a long period of time? What are the long-term side effects of those medications? So it goes both ways. We often get patients here who we find out do not have seizures, and we successfully wean them off the medications they don't need to be on. They feel relieved, and they feel much better.
Right. Okay. Before we move on to EEG and neuroimaging technologies, does anyone have any questions so far?
I have a question. I'm Marissa Morgan, and my question is in regards to the auras, they call deja vu. There are some people who I've talked to who've had deja vu feelings, but they haven't had epilepsy symptoms.
Correct. And that's one of the harder cases where, first of all, there's many different types of auras. Deja vu is just one type of aura. There's, so many that you can't even count how many there are. And you are correct that sometimes patients have symptoms that are, I'm not going to say that they're vague, but they're not the most specific. And that's, if those things persist, that's when I would say, hey, listen, you need to be evaluated at least by a neurologist or an epileptologist.
Oh, okay.
And is there also a distinction with deja vu in particular? Because I know a lot of people have experienced deja vu and they don't have epilepsy. Mm-hmm. Is there a distinction in terms of the intensity of it and the duration of it?
I don't think so. Okay. I don't think there's not a specific duration or intensity. Often you ask the patient, what else did you have with it? Did they know, did the family notice anything else? That kind of makes it a little bit of a giveaway.
Mm-hmm. Okay.
Any other questions before we move on? Okay. So EEG is obviously one of the most important diagnostic tools for epilepsy. Can you give us just a quick overview of the different types of EEGs, when they're used, what their limitations are, and what their benefits are?
So as a whole, okay, EEG is still the main diagnostic tool. It does have quite a subjective component to it in terms of its interpretation. The basic one, and I'm telling you because I see mainly adults, so I'm going to sort of focus in on that area, is a routine EEG, which is really about a 30-minute study. There is, in some cases, once we have done that, okay, we don't have an answer, or we have an uncertain answer, then we sort of up the ante to the next level up, which would be either a sleep-deprived EEG, which is basically where a patient is we purposely do not allow them to sleep a lot the night before the study, or we do a longer-term study with a video. This could be done as an outpatient or an inpatient. So let's say 4 hours, 6 hours, 8 hours. And then one step up further from that, if that doesn't give us the information we need or help us, then we would do what we call an inpatient stay, which is in the epilepsy monitoring unit, which is often a multiple-day stay, including daytime and nighttime with various activation procedures. I won't necessarily go into, for sake of simplicity and time, but then there are what we call, all of those EEGs that we talked about monitor from the scalp, the surface. The internal intracranial EEGs, which are often what we call depth electrodes and subdural, those are more for patients who are being considered for epilepsy surgery.
And does Spectrum offer ambulatory video EEG monitoring? Because that's kind of a new thing that I've heard some places offering, where you can have video EEG monitoring at your home rather than admitted. There's obviously risks associated with that. So, but I'm just curious what different health systems are doing in terms of that.
Yeah. It actually depends on, that is almost, I can tell you, there's so much variation. We as a whole have a very limited to minimal capacity for that. Yeah. And that's probably because most of the epileptologists here prefer not to use those type of studies. Mm-hmm. Now, I will tell you, it is, ambulatory EEGs have been going on for years. The newest add-on to that has been taking a video component to that home. I remember where I used to work, that was available there as well. The other thing is, with technology on those has improved, that they can allow a longer duration recording from home without switching out batteries and that type of stuff. But as you said quite appropriately, there is a safety issue. The other component, and this is something that it's never written, but different states have also, different insurers have slightly different requirements on ambulatory EEG, so that's also now been playing a role.
Sure. As far as some of the things that are done to try and provoke a seizure in a inpatient setting, or what are the standard things that are tried? Are there things that there's any debate about whether it's safe to do or not? Can you just talk a little bit about the different things that are used and again, whether there's any varying opinion on those?
There is. A lot of the stuff, you have to also have to realize that some of the stuff that even I have never been exposed to, based on the time I've been in practice, ethically, that they used to do is no longer possible. Remember that we always have to think of one thing, and that the purpose of the stay is diagnostic, but also to keep the patient as safe as possible, not putting them at any additional risk than necessary. So the common things that are used are such things as hyperventilation, so deep breathing is hyperventilation, photic stimulation, which is basically a light stimulation or flashing lights. We use sleep deprivation. And of course, the biggest thing that we use is we decrease, and in some cases stop, a patient's anti-epileptic medication gradually.
Okay. And what about someone on one of our calls, that I can't remember who it was specifically, but mentioned actually using medication like giving the patient medication to induce seizures. Is that done or no?
I would say no. My answer on that one would be no, because ethically it's a bit of a fine line, and most institutions are shying away from that.
Okay. So obviously, taking the EEG is one thing, but then interpreting it is another. So what special training is needed to correctly read an EEG, and then how often are they either under or over interpreted by doctors who may not have the sufficient training to interpret them?
I'll tell you, as I said, there's a lot of subjectivity to the reading of EEGs. Technically, any neurologist does not have to be a specialist in seizures like an epileptologist can read an EEG. But, my preference, if I had my way, would be that, if I had an EEG, an epileptologist read it, because an epileptologist has had additional training beyond residency, specifically looking at EEGs. Now, even amongst a group of epileptologists who are well-trained and well-experienced, there is subjectivity in the read, so there can be disagreements, and we have those all the time. Those are the times where sometimes, let's say that came up on a regular EEG, a short one, we would say, okay, let's move to a longer one and see if we can replicate that finding. That's how we sometimes overcome that dilemma. The other thing is, it's not just the reader, but the quality of the study. So epilepsy centers have, a good number, most of them have a reasonable number of technicians that are registered, so the hookup quality of the study, the quality of the hookup has to be good in order for a good interpretation to be performed.
Right. Are there any common misinterpretations that you see often that
yes.
could be prevented through better education of general neurologists? Not
necessarily prevented. A lot of it is some which are technical aspects to the study. If the patient's moving too much, some of the most simple things is certain movement artifacts look like seizures on an EEG, but they're not. Other interference, electrical artifacts. The read is only as good as the quality. So often there are times where, even with the best intentions, the quality of the study doesn't come back well, so we have to repeat the study.
Yeah. Okay. So are there circumstances when a normal EEG would actually cause a doctor to rule out epilepsy, and then what circumstances would a normal EEG prompt longer or more invasive EEG monitoring?
The easier answer is the second part of the question. Is, first of all, about 33% of patients with epilepsy, okay, and this is a rough figure, actually have normal EEGs. So a lot of times when you see a patient, they'll say, you just diagnosed me with epilepsy, but everybody's told me my EEG is normal, and so are you. Are you sure about this? And so, first of all, a normal EEG doesn't rule out epilepsy. The other thing is partial seizures are often not picked up on an EEG. Okay? But that doesn't rule. That's why the clinical diagnosis is the key thing. Where you need to do the longer studies, first of all, if you're thinking of somebody for surgical intervention, yes, you do have to do a longer study, absolutely, and probably with invasive electrodes in some cases of those. Now, on the other hand, if you have a patient who has a normal EEG and still has spells that you are not clear whether they are epileptic or not, or they have varying different types of spells, more than one type, that's when you need to do the longer EEG monitoring. And the one last reason, which is, again, not just the last one, but one of the other important reasons, if you feel, and this happens with a lot of patients who have developmental delay or cognitive impairment, if the patient is still having what you feel are subclinical or electrographic seizures that are not seen outwardly or clinically, those can only be picked up with EEG monitoring and usually require longer-term monitoring.
Okay. And in terms of the interictal versus ictal abnormalities, I guess, are there types of epilepsy that are more likely to have interictal abnormalities as opposed to other types which are unlikely to have interictal abnormalities?
That one, I don't have a direct answer for that one. The thing is that the more active somebody's epilepsy is, like for example, if my normal frequency is 3 seizures a week, whereas yours is maybe 1 every 3 weeks, the odds of finding an interictal abnormality are probably higher on me than on you, just by numerical odds. But remember, and I think that's where you hinted this quite, and you made that statement quite accurately, is just doing a regular EEG that most people start off with. Just because you don't capture a seizure, an actual seizure on there, doesn't necessarily rule it out. In fact, a lot of times patients will ask us, they'll say, well, doc, so you're doing this, and you're trying to give me a diagnosis. What if I don't have a seizure during it? Remember, the majority of people don't. Yeah. It's when you look for interictal activity, and sometimes you don't even see interictal activity.
Right. So the likelihood of interictal activity is more correlated with the severity of the epilepsy.
You got it.
Than the
yeah,
type
and
of epilepsy.
severity, duration, and frequency.
Okay. So if a person's EEG is normal during a videotaped episode, so they actually you see an episode, they're having something that looks like a seizure, but their EEG is normal, does that necessarily mean that the episode is not an epileptic seizure? Could there be abnormal electrical activity that's too deep to register, or could it be
Absolutely, yeah. That is, and we've had, I can tell you, numerous cases of that here at Spectrum, some of which I've been involved with personally, that as you said quite accurately, you record an episode, you have the EEG running, you've got a videotape, there's no change. What do you call it? Well, at that point, you've got to add up all the rest of the information around, what type of episode was it, how did it look. The reason is that EEG has a limitation, and the limitation is that it only records from the scalp, from the surface. However, if somebody has an epileptic focus that is deep beyond the surface of the brain, it may not be able to pick it up.
Right. And are there regions of the brain, like different lobes, where it's more likely to have a deep focus?
Yeah. So one of the hardest ones is actually the middle, what we call midline region. So frontal lobes are hard, okay, but also middle front is even harder. And you can probably think, just if I was to put a cap on you, hypothetically, with the surface electrode, the middle readings are going to be the hardest to see. Also deep into the temporal lobes, okay? Because remember, the brain is a 3D structure, so if I was to open the brain up on the inner side, that's where things get a little bit more dicey.
Right. So if someone has been told that they have psychogenic non-epileptic seizures based on the fact that they had a videotaped episode with a normal EEG that went along with it, and they really believe that they have epilepsy or they're not comfortable with that, do you recommend that they seek a second opinion, or that they persist with trying to do more testing to show that they may in fact have epilepsy?
I would say in that situation they should seek a second opinion or further evaluation, and part of that, once they've seen that professional, will probably be, hey, we need to get a longer term monitoring study or something like that. That would be the step.
Okay. And then other than pre-surgical evaluation, when should a person who's already been diagnosed with epilepsy get another EEG, like a second EEG? Is it something that there should be routine follow-up, or only under certain circumstances?
Generally, we don't repeat. I was trained not to, and neither do my colleagues here, repeat at a fixed frequency. Yeah. What I worry about, or when we need to get another one, in fact, I had a case about 2 weeks ago about the same, is when somebody says, or their family says, okay, my son is now having more seizures, they've changed in type, or they've changed in duration. Then I know it's time to get another one.
Okay, before we move on to neuroimaging, does anyone have any questions about EEG? Okay. So MRI, or magnetic resonance imaging, is probably the most important neuroimaging technology in diagnosing epilepsy. As you mentioned earlier, it's preferred to CT scan in general. But can you give an overview of MRI in terms of when it's used, what it shows, and then also like how important the strength of the magnet is and things like that?
Okay. Before we get to, I just want to backtrack on one thing, and I'm sorry, because you had mentioned, you had given a question, you had asked about, interpretation of EEGs, what other things could be misinterpreted, okay? And there is one additional item that comes up often, and that is there are certain things, and this is something that the interpreter only gains by experience. Also, our EEG technicians with experience get versed in this. There are certain electrical phenomena in the brain. Remember, an EEG records electrical phenomena. That's the key. It's an electrical recording. But there are certain electrical phenomena in the brain that are considered normal. We call them benign variants. And they sometimes look like they're epileptic, but they're not. So they look like intraictal epileptiform abnormalities, and that's why the more trained and more skilled your reader is, the less likely they are to call something that is benign and normal as abnormal. Going to the MRI, like you mentioned, the MRI it's become a staple now in epilepsy evaluation. Years ago, it was actually X-rays, skull X-rays, rather than even CTs. The MRI is basically what I call a picture of the brain that's done using a magnet, a magnetic field. The strength of the magnet differs in different places. In a perfect world, I would say we should use the highest strength of magnet possible. But sometimes it's not available in all cities. Sometimes it's not possible because the patient has other conditions or instruments that they have implemented that doesn't allow the highest power magnet to be used. Right. So in a perfect world, the number you'll often hear, it's called a 3T, just like the number 3 and T is for Tom, a 3 Tesla magnet. But have I used other ones? Absolutely. What does it show? Generally, and this is where things, again, are very similar to an EEG. Remember we said at the beginning that you could have epilepsy and you could have a totally normal EEG. The same thing could apply. You could have epilepsy and you could have a normal MRI. So that doesn't exclude it. Now, the difference is, let's say I did an MRI and, God forbid, I found a stroke or I found a brain tumor or I found a bleed after somebody had fallen a week ago or two. Well, that's pretty obvious, right? We can find the abnormality. We say that's the cause of this gentleman or lady's epilepsy. But the other thing we look for, and this is where it gets very important on the reader, that is the neuroradiologist, is very subtle malformations of the surface of the brain and the depths of the brain. And these are subtle malformations that a person wouldn't even know necessarily that they have. They could be born with them. And the higher the power of the magnet, the easier it is to see these, what we refer to as cortical abnormalities or malformations. And what we want to see is, where are they, in terms of location, and is that the area, generally that should be the area that the seizures are coming from.
And is MRI generally recommended for all cases of epilepsy, or are there times when you don't order an MRI?
I would say, so standard of care actually is an MRI. American Academy of Neurology does recommend an MRI. The only time, which let's say that we don't do it, is if somebody's got a bunch of metal in them because they just can't, it would be unsafe for them to have it. Some of the older, now bearing in mind these are older devices, the older aneurysm clips and stuff like that, which would be a contraindication to MRI. But I'll tell you, even the newer pacemakers are now pretty much MRI compatible.
Okay. And what about cases where a patient doesn't have insurance? Is that a case where you might
that's
instead because they might be able to pay out of pocket for that?
I'm not, and I'll have to. I don't have the current figures on me. Obviously, it will depend on the institution and the area. I will tell you one thing. Yeah, in the strictest sense, CAT scans are less expensive than MRIs, but the cost of MRIs, because of the ubiquity of their usage, has also come down considerably.
And are there any?
Can I ask about the VNS with MRIs?
Yeah, the VNS, the vagal nerve stimulator, needs to be turned off before an MRI. Okay? Now, that's one of the cases where some institutions prefer using a lower strength magnet as opposed to the higher strength one.
How low?
I've seen 1.5s and 0.75s. But again, that's also, it also depends on the institution. Every institution has a different, in terms of safety, what they feel comfortable with. And that is not even up to the neurologist sometimes, it's up to the radiologist.
Mm-hmm.
Okay. Are there circumstances under which a CT would be used instead of or in addition to an MRI? Is there any advantage to a CT other than the lower cost?
Not necessarily. I mean, one time I've heard someone say that a CT shows fractures better, but it's not, the fracture is not determining your treatment. You're looking, so I would say no to that.
Okay. And again, similar to the question I asked about EEGs, are there times when people should get a second MRI, or should that be repeated every
that
5
would be
years or something?
Well, for example, the easiest example is if someone has, they've had a brain tumor, and let's say it's been taken out and they've had seizures as a result of that, and they come to you and they say, hey, wait a second, I'm having new neurological symptoms or I'm having more seizures, absolutely, you need to get another MRI. On the flip side, if it's somebody who doesn't have, a brain tumor or a stroke, and again, their seizure frequency has markedly changed in 2 years, there's a little bit of subjectivity to this, but if there's been a marked change, or for that matter, let's say they had a couple of seizures with a severe injury or two, then I think it could be justified to get another MRI.
Right. Okay. For what about like people who had their MRI 10 years ago or something like that, or 20 years ago?
Yeah, that's where there's no hard number, right? There's not an expiry date like we have on our driver's license.
Sure.
But I can. But if you were to come for a second opinion, okay, to an epilepsy center like Spectrum, and again, the ultimate decision is with the individual provider, but we like to see something generally within 5 years.
Okay. And has the quality of MRIs improved enough in the past 10 or 20 years that would be another justification to getting a new?
Absolutely, and that's the thing. Sometimes what was not seen in one in 1992 or 1995 may be seen now because at that time maybe the power of the magnet was less.
Yeah. Okay. So there are a number of other less often used neuroimaging technologies and also MEG, which is more closely related to EEG. But can you talk a little bit about these and their role in diagnosis? Many of them are used, again, more often for pre-surgical evaluation, so we don't really want to talk too much about them, but are there cases in which PET and SPECT and some of these other technologies are used in the diagnosis or in the process of diagnosis?
Generally, in the diagnostic process, they are not used. They're used, and you said it appropriately, when a person has uncontrolled seizures and they're being considered for surgery, okay, or even, let's say, a partial resection. But to order those as a whole, first, when you first see the patient, I would say most of us do not do that. There are investigational, research studies where they may be ordered first. That is an exception to that. One of the studies you will hear, a SPECT scan. There's a version of a SPECT scan, which is an ictal SPECT, which is something that is often used in the epilepsy monitoring unit when someone has a seizure there. So that one's kind of a little bit of a standalone. But PET scans, functional MRIs, and MEG studies, they are generally used when a person has been diagnosed with uncontrolled / drug-resistant epilepsy. The refractory epilepsy is the other term they use for it. And we are working them up for potential surgery.
So can you talk a little bit about SPECT, since you mentioned that it may be used occasionally for diagnosis?
SPECT, okay, the ictal SPECT, and we don't use that here yet. It's there's a process to get it, and we're in the process of hopefully getting that approved, is where there's a radio tracer, a radioactive dye that is injected into the patient right at the onset of their seizure. So you can imagine precision and timing is there. So this is when a patient comes into the epilepsy monitoring unit. They're in the unit. We're recording their seizures. They have their seizure, let's say exactly right now at 12:55. The nurse runs over there or the technician runs there. They inject the dye. The patient gets taken to the scanner downstairs so that we can see which part of the brain lights up at the time the seizure begins.
And are there any other diagnostic tools used in epilepsy that we haven't talked about so far? There's ultrasound, blood tests, lumbar puncture, some other things. Are any others that you think that you use occasionally that people might run into?
With respect to the examples that you gave, these are things that you often use if you are working towards that diagnosis, say, does this person have epilepsy or not? These are often inpatient tests like lumbar punctures. You generally would not do that in someone who already has the diagnosis of epilepsy, an existing patient. This is like you're trying to rule out other things. Yeah. There is one item that you mentioned, though, which is gaining a lot of traction over the last few years. In fact, in the last 5 years, is genetic testing. Genetic testing, there is a little bit of controversy. First of all, there are more genetic tests that are available now than there were even 2 years ago. Okay, a lot of these are very specialized tests, and they're very expensive. And some people say, well, why do we need it if it doesn't really change how I'm going to treat the patient? Okay, but there is in the research sense, there is a good move in research right now. Eventually, once we've honed down some of the genes, that is the particular genetic area linked to different types of epilepsy. Remember, there's not just one area, there's many different types of epilepsy. That might be able to further pinpoint and hone down our treatment.
Right. So related to that, one of my wife's coworkers had just had surgery for a brain tumor. The brain tumor caused a seizure while she was driving, which led to the discovery of the brain tumor. They removed the brain tumor, and now just recently her son had a seizure, and she is obviously now totally thrown for a loop because she doesn't know, well, was the brain tumor actually the cause of mine, or is there a genetic component? Should I be worried about my daughter? Should I have her tested? So in situations like that, is genetic testing something to consider? Obviously,
yes and no.
You know more about the situation, but
exactly. The answer is that not. You remember that the majority of cases of epilepsy are not hereditary.
Right.
They can be spontaneous. They can begin at any age. And sometimes that's a hard point to understand, because if you begin to think, wait a second, okay, first of all, do I really believe the diagnosis because nobody else in my family has it? On the flip side, like you said, for your colleague and your friend, it is a concern when one person is found and in a short period of time, even if another one isn't found in the family, it's like, oh my God, are my younger siblings or my children going to have this? We're seeing, because of this, as I mentioned, because of the increased availability of genetic testing, we are getting that question more often. Years ago, that was really not a question that was brought up. One thing that I always tell people when it comes to any type of genetic testing is, what we call it is, we would refer them to a genetics counselor, okay, where they can kind of delineate the family tree and do like a pre and a post-test counseling. If they're in agreement after that, that's when we proceed on it. But as as a routine, just as a off-the-wall test, I wouldn't do it.
Right. Okay. So we mentioned a little bit earlier about insurance issues, and if someone is uninsured or underinsured and they need additional diagnostic testing but they can't afford the out-of-pocket costs, what are the different ways of dealing with that? How does a patient prioritize what's most necessary? How are there programs that can help? And that all depends on the health system, I'm sure, but how do you deal with that in general?
That's a difficult question, but as you said, it's a reality that our society is seeing sometimes more than we want to see. Often what I do, and I think most practitioners do this, is of the big tests that we have to do, which includes an MRI and EEG, we try to prioritize, which one of those two is the most essential. Like, let's say one of those patients has already had a CAT scan. That's where you kind of put a little bit more weight on the CAT scan, and if it's recent. On the other hand, if it's an EEG, we try to start always with the shortest EEG so that we're not wasting money in that situation. And then if that doesn't give us the answer, we think about a long term. Other times, patients will say, well, okay, with the financial assistance that the institution offers, I can try, a 6-hour one so we don't do the 24. We see if we can get the information that we need on a shorter study.
So most of what we've been talking about has been diagnosis of whether or not you have epilepsy, but diagnosis should also provide information in terms of what types of seizures the person is experiencing and what types of epilepsy the person has, whether it be an epilepsy syndrome or temporal lobe epilepsy versus frontal lobe epilepsy. I would say probably the majority of people who call us don't know what type of epilepsy they have. They might be able to name the seizure types. Sometimes they say, well, I have the grand mal and I have the petit mal. And when you actually ask about petit mal, they're not really talking about absence seizures. They're talking about other seizures besides grand mal. So how important is it for people to have as much detailed information about their epilepsy type and their seizure type, and how often are neurologists able to provide that level of information?
There's a two-part answer to that. Is that, first of all, if you're not being treated by, if your seizures are being managed by a non-neurologist or non-epileptologist, that's where the patient may not necessarily be told, again, not purposefully, the exact type of epilepsy they have or a syndrome, because they just don't see it as often as we do. And that even occurs with the general neurologist. Now, sometimes knowing that information does not impact the type of treatment that they receive. Sometimes it does. From a patient perspective, even if I was the patient, whether it's for epilepsy or anything, as the old saying goes, the more knowledge you have of it, the better the understanding you have and the better the acceptance. So that is another reason why we recommend, patients are at least seen once in consultation by an epileptologist or a subspecialist in seizures. And what it also does is it helps clarify sometimes what I call and as you hit quite accurately, what they're calling as petit mal seizures are not really petit mal seizures. The little wrinkle that's thrown into this is that when we see the patient the first time, remember, we're putting together and we're synthesizing from the history. So on the first time, I may not know the exact type. Right. So it's only after investigation can I narrow it out. And the other thing is, I will tell you from a nomenclature standpoint, there's a little bit of controversy, and there is constant realigning and changing of the names. Even from the time that I was in training, they've changed some of the names. So that's a dilemma that even we as physicians are faced with, and sometimes we wonder, why can't you just leave it the same so that we can explain to our patients better?
Right. So, an example of that is like whether it's called partial or focal or localization related. Exactly.
Or localization related.
Is there any clarification on that or a consensus on that yet? Have neurologists shifted from one to another, or are they tending to stay with the older nomenclature? Because I don't know myself what to use anymore when I talk with people. So.
I unfortunately don't know the answer to that one. I myself, because like I said, I've heard so many versions of it. Maybe this year's epilepsy conference, which comes up at the end of the year, might shed a little bit of light on that. That's generally when the trends come out.
Okay. So what, in terms of the types of information or types of details you can get related to your seizure type and your epilepsy type, is there a minimum expectation? I mean, after several visits, let's say, not necessarily initially.
Yeah,
but
not even after a couple, not even necessarily, sometimes even on the first one, would be the minimum that I would recommend, and actually that's what, that's what a good quality visit gives you would be, a narrowing out of the type of your seizure, okay, the frequency of the seizure, the cause of them, okay, and then why the particular treatment that you're on. So medication A versus B, why A is better than B for your seizure type, if it's that. What other possible choices there are besides A or B, say that if in the future medication needed to be changed. And the other thing that you need, that the patients gain out of it is a knowledge of the potential side effects of these medications. That way, if they experience them, they're better able to delineate it.
Right. In most cases, are epileptologists able to determine at least whether the epilepsy is partial or generalized or
yeah,
both?
I think in most cases, yeah, they are.
Okay. And in terms of cause, I've heard statistics where 70% of cases the cause is not identified, but I don't know.
Yeah, that's correct. That 60 to 70 number still applies.
Yeah.
Now, bearing in mind with all the the questions we had asked about technologies and stuff, most people are predicting that over the next 10 years or so, that number will go down from 60 to 70, perhaps even slightly less than 50%.
Right. Okay. Let's open it up for questions, and then if we don't have many questions, I have some other things I can ask. But does anyone have any questions at this point about anything we've discussed? Okay, I'll let you think about it. But would you be able to give a few examples of some cases you've experienced where a patient was misdiagnosed or where the process of making a diagnosis was challenging, and maybe some things that you learned out of that process that could be beneficial to the healthcare providers and patients who are listening?
Sure. I think the right adjective, and I like that, is cases where even we were challenged as a group here at Spectrum. One example was a young lady just in her late teens that came in with symptoms of what I'm going to refer to as tremors, and both the patient and her family felt that those were her seizures. Mm-hmm. Now, the interesting thing was we captured those in the epilepsy monitoring unit, and there was no electrical correlate to those. Right. But she had other sudden jerks that we did capture that were correlated with epileptic discharges. So we didn't doubt. She did have a history of epilepsy. But in this case, the important finding was what they were thinking were the patient's seizures were not, and what they were thinking were not actually were. And the purpose to that is it helped us delineate more accurately the patient's actual seizure frequency, and so that we could adjust her medications appropriately. Right.
Can you think of any examples with psychogenic non-epileptic seizures where, because particularly with people who have both epileptic and psychogenic seizures, are there cases you can think of where you were able to help them distinguish between which ones were epileptic and which ones were psychogenic? Because that could be useful information for the patient.
Absolutely, yeah. There have been cases like that. One of the other most remarkable cases was where a patient had come in with their family with two different prior opinions. One person said that that they did have epilepsy, another person didn't. And you can imagine, even if it was you or me, it doesn't make you feel well when one person says yes, one says no. So our job is to, as best as possible, try and clarify. And the reason that it was a dilemma in this case is that this patient's seizures actually involved walking in a circle and bending sort of at the knees, like if their seizure manifestation was basically bending at the knees repeatedly, like you were exercising, and then walking in a circle. So a lot of these patients were, like this patient was diagnosed with a, quote, mood or behavior issue. Now, my suspicion is that he was still having seizures, and I proved it through an epilepsy monitoring unit today. The reason that his seizures were so bizarre is because his seizures were coming from the frontal lobe.
Right. So I've heard a lot of examples of that where the frontal lobe seizures are very unusual in the way that they can come across, and people are not familiar with that. What are some other examples of seizure manifestations that are actually epileptic seizures, but that don't fall into any well-known category or well-known description of a seizure?
Some people can have very unusual auras. We have seen, I have a patient who actually has an aura, it's a visual aura that actually that is so scary that it causes him to scream as if he's watching a horror movie. And the scream is so piercing that when we first heard it, actually even our staff, some of our other staff members were quite frightened. But his aura is actually that consistent aura followed by a grand mal seizure.
And another thing in terms of psychogenic non-epileptic seizures, obviously the gold standard for distinguishing between psychogenic non-epileptic seizures and epileptic would be video EEG monitoring. But are there other typical, as far as the descriptions of what's happening during the seizures, are there other red flags, I guess, when someone describes a seizure that make you think, okay, this might be psychogenic?
There are. Particularly you think about, was there a postictal phase? Was there not? Was there any injuries? But I will tell you, when you start, and experience also tells you this, those are the typical things that you ask about. But when you're dealing with atypical seizures that you often see in like a level 4 epilepsy center like Spectrum, all bets are off because frontal lobe seizures don't have a postictal phase. Some of them the patients snap out of them so quickly it's as if nothing happened, and they have no recollection for it.
So it sounds like frontal lobe seizures are one of the most challenging in terms of, and probably one
absolutely.
of the most
Frontal and parietal lobe seizures.
Oh.
And parietal lobe seizures are also very unusual.
Okay. Does I think
I do have another question.
Thank you.
Maybe I missed it. I don't know what a psychogenic seizure is.
Okay. So a psychogenic, there's actually different terms for this now, and again, that's where the terminology is changing. A psychogenic seizure is often referred to as a non-epileptic seizure, and in essence, this is an event where it looks like a seizure on the outside, however, it's not associated with electrical changes in the brain, so it is not a seizure due to an electrical phenomenon. It is the body's response to a stressor. It could be internal, it could be an external stressor, it could be current, it could be past, does not have to be recent. Even such things as pain could be a trigger.
Yeah, and often.
Do you treat them with medication?
Yes, it's actually combination therapy. Now, you don't use anti-epileptic medications for it. That's the key. But yeah, there is a combination of things that you could use for it.
Yeah, and often psychological counseling is common treatment for that.
Multimodality therapy.
Yeah, some people who have psychogenic non-epileptic seizures have a history of some kind of psychological trauma like abuse or something like that, or they're currently going through a lot of stress, or the stress of dealing with epilepsy itself may be a cause. So often, like Dr. Ardeshna said, it's a combination of counseling to deal with those stressors, and then possibly medications to help manage the stress as well.
And often those patients have some mood-related issues as well.
Is this frequent?
I'm sorry, can you say that again?
Is this frequent, finding these kinds of seizures?
Well, I don't think there's an exact percentage. Nobody's done a study to say that it is an exact percentage out there. Do epilepsy centers like we have see these type of things frequently? I would say overall, yeah, it can be seen quite frequently.
Right, and we'll at our conference, just so you know, Judy, we'll be having a session on psychogenic non-epileptic seizures. So if you're interested. Okay, someone else had a question? Sorry.
Yeah, I wondered, he mentioned that the parietal lobe does present unusual, like the frontal lobe. How is it different? How does it present differently?
That one it also varies. Parietal lobe seizures can have, frontal lobe is often associated with hypermotoric activity. These are often patients they run during their seizures, they have a lot of exaggerated body movements, and they come out of them quite quickly. Parietal lobe seizures often have very unusual auras, such as a feeling like somebody is being elevated or levitated. Just some of the most unusual stories.
Okay.
I have a question. You just made mention about mood-related issues. Can that be correlated with bipolar disorder?
Yes, that is one of the possibilities. That is correct.
Okay.
And bipolar disorder, along with depression and generalized anxiety disorder, are all found at a higher prevalence in people with epilepsy than in the general
Correct. The two biggest ones are depression and anxiety.
Yeah.
Okay.
Okay. Other questions? Okay, well, we're a little before our end time, but if no one has any other questions, I think this is all exceptionally useful information. So thank you so much, Dr. Ardeshna, for
thank you, everybody.
Your insights, and this will be added to our website, the recording will, and so hopefully people can let other people know about this if they have questions about diagnosis. So thanks again, Dr. Ardeshna, and thanks everyone for participating.
Thank you, Thank you, Dr. Ardeshna.
Thank you.
Everybody have a good day.
Thank you.
Bye-bye.
Bye.